So we've had a 50-year-old lady come into our emergency department. And if you can go back to sort of your medical school, put your investigating cap on. We're at an aortic forum, so I'll give you a hint. That's what we're focusing on. In terms of her symptoms, this lady's come in with shortness of breath and chest pain, quite unwell. History and exam occur concurrently, and clinically, she's in a diagnosis of congestive cardiac failure. So in terms of our salient points from a medical history, she's recently been diagnosed with pulmonary emboli, and she's now been treated with warfarin. Now, like all good physicians that are focusing on the surgical area of medicine, we take a thorough surgical history, and the most salient point to come out of that is that this lady's had 3 prior operations. And now she's had them at the ages of 5, 12, and 29 at a different country, at a different location. So it's starting to sort of pique our interest a little bit to know what's happened. Essentially, this lady's had coarctation of the aorta. Now, her first operation was at the age of 5, and then at the subsequent ages of 12 and 29, she's had further interventions with grafts put in. The first graft was a 13 millimeter, the second graft a 20. So putting those all together, this lady's quite sick when she comes in. She's got an interesting medical recent diagnosis. She's got an interesting surgical history, so she scores a ticket to the scanner. This is our CT that's playing for you now. If you focus on the aortic area, we're coming down now the thoracic cavity, and things start to get a little bit interesting and doesn't look quite right. And we've got very small vessel caliber coming down the thoracic cavity. Something next to it that's not quite right. And then we start coming down to a little bit more normal caliber vessel as we head down the thoracic cavity. So there's something not quite right in the chest in terms of her aorta, and we need to do a little bit more investigations. So we do a 3D reconstructed image. This is what you see here now. And as we're coming around the chest, you can appreciate that there is a small caliber vessel, which is the previous 13 millimeter graft that's still patent. Now the dodgy area next to it that's not quite highlighted is the 20 millimeter graft, which has now been thrombosed. And there's a proximal 5.5 pseudoaneurysm just past the left subclavian vessel. So her rest of her body is being perfused through that 13 millimeter graft that was operated on back when she was quite younger. At the age of 29, that 20 millimeter graft, 21 years later, has now thrombosed. So with those pictures in mind, I'd like to now throw it open to the forum. What do you think's going on? Why has this occurred? And what is your management going to be?
Something simple to do, along with some basic ECG and troponin. We have pretty sure already, but echo on the bedside for him of a really differentiate by extent, whether it's proximal, distal, extent.
Can you try and speak into the microphone?
And whether it involves the aortic valve or not, and in terms of CCF, whether or not there's pericardial effusion, and extent of whether the dissection and the pseudoaneurysm is confined to the area of the coarctation itself or not. So that would be my first goal. Bedside echo right away, proximal, distal, myocardial function, aortic valve involvement, pericardial effusion, and take it from there.
In terms of heading forward, does anyone have any ideas as to why this has occurred? So my understanding is so what has happened is that 13 millimeter graft that initially got put in just past the subclavian.
Yeah. End to end.
Yeah, when she was.
So she's had an end-to-end repair of a coarctation. That was her first operation with a 20 millimeter graft. Okay.
13, sorry.
13 millimeter graft.
Yeah.
Okay. Then what?
Then bypass graft, the 20 millimeter, the third one, or the last one.
So she was reoperated on through the left chest.
Yes.
The previous graft was taken out and a bigger one was put in.
No, the previous
So
graft at 15 millimeter was left in place.
Left in place.
And they
Okay.
put a bypass, which is the bigger graft.
Okay. Right. Third operation.
So the first operation was at the age of 5. They've just repaired the coarc. There was no graft put in
The
place.
first operation without the graft when she was young,
Okay.
it was just a resection and end-to-end anastomosis.
Okay.
Then a 13 millimeter graft,
Then a bypass.
then a bypass graft. So the last one, the big one, is the bypass graft.
Okay.
Yeah.
So So now what you're saying is that her graft is thrombosed
Correct.
Yeah.
and she's left with just the original small graft perfusing distally.
Correct.
Okay. So I think, firstly, why she come in with chest pain. Don't quite understand that, but it's an indication that there's something not very good going on there, isn't it?
Yeah.
Okay. Second thing is, do you want to leave somebody this young perfused distally with such a small graft when she's obviously got a tendency to thrombose, even though she's on warfarin for a pulmonary embolus? And the answer to that is probably no. So for us, we go through a little sequence of very simple questions. Number one, do we need to intervene? Number two, if we need to intervene, is it going to be open or endovascular? Okay, for most cases. So I think we should probably intervene. And I'm just looking at this and I'm thinking, well, we've got a big circle at the top, we've got a big circle at the bottom. I'm probably going to put a graft in to join those two up. That would be my feeling.
Roberto?
What do you think of that false aneurysm as well at the top there?
Well, I would go beyond that. Because I think you've got a big tube at the top, big tube at the bottom. You can exclude everything.
Your question.
There is a false aneurysm at the top there,
Yes.
just where the old
yeah,
operation
yeah.
was.
Can I persuade everyone to use the microphones? I'm so sorry for the
The question is whether the pain is due to some kind of a imminent leakage from the false aneurysm. So that's probably where the urgency lies. And she clearly needs an orthotopic replacement rather than a bypass. And the question also arises as to whether there's an infective component in this. You certainly want to look for septic markers.
Is there anyone else on the floor that has any comments or questions they want to ask? Or
But the patient have a bicuspid valve? Or no?
Didn't have a bicuspid, no.
No, but ascending aorta aneurysm.
Sorry?
This is an aneurysm of ascending aorta also. How many centimeters is ascending aorta?
So the aneurysm was 5.5.
5.5. And the valve is normal, is tricuspid,
The valve wasn't bicuspid, no.
is a normal function or no?
Sorry?
The aortic valve, is it normal function?
Normal function for the
normal
valve.
function.
Roberto's worrying because he's trying to make it even more complicated.
I know,
what
because
he's saying is
the
I
patient
think
have,
the ascending aorta
no,
is
before,
well.
no, for me, in these cases, you want to know what is my program for these patients?
yes, please.
Huh?
Yes, please.
In this case, it's possible to perform the repair of ascending aorta, and if the valve is good, to meet the aortic valve sparing operation, to open the arch and close the arch after the left subclavian artery, and to perform the operation, the Cooley operation, the prosthesis from the ascending aorta to the abdominal part of the aorta, upper the celiac trunk.
And I was pretty concerned about what George have said earlier on, the leaky aneurysm as the cause of the pain. So the echo didn't show much apart from a dilated hypertrophied ventricle related to hypertension, and nothing else. The valve was normal. I do agree with you, the ascending aorta is a little bit big. And the question is, which one would you tackle first, and what would you need to do?
I think unfortunately you still have to go left chest and be prepared for a deep hypothermia from the left chest. It'll be messy, but that's the only way to go, I think.
Wonderful. So I think that's about 7 minutes of discussion. Shall we move on to see what we actually did?
Yeah.
Thanks, Damian.
So following on from that last comment from Prof. Matalanis, they did have a third redo through the left side of the chest, and a 24 millimeter graft was inserted. Now, it was through a left thoracotomy. There was very fragile tissues, and at what was alluded to earlier, that you can appreciate that the views were very difficult, and it was a difficult access. So just some intraoperative photos. This is the pseudoaneurysm that we were discussing about at the proximal end of that 20 millimeter graft. And when it came out of the chest, there's your thrombosis that was present inside the graft. So in terms of what we did, here's the next 3D reconstructed image, which will show you the bypass now with the 13 millimeter and the 20 millimeter both excised. And it's now patent through a 24 millimeter graft. So what happened? Why did this occur? That whole theory of competitive flow. So there was a 13 millimeter and a 22 millimeter both patent with competition of flow throughout the rest of the body, different forces of velocity going through those tubes. So really there was a need to ligate off that initial 13 millimeter graft once the 20 was inserted. And really the take-home message from this, if we just bypass a little bit from the aorta, is that anything that happens in an operation has further indications down the line, particularly for redo operations. So bearing that in mind, whatever you plan, you need to anticipate that you're coming back the next time.
So, Roberto, the last scan, her aorta is 5.2. 5.2, yeah, the ascending aorta. So it's big, and she still have a competent aortic valve, and her blood pressure now is much, much better, is well under control. So maybe she needs a 5th operation to tackle that, but I don't think I wanted to do it.
Any other questions or comments? Okay, thank you very much.